about renal disease, and there's two different categories, I guess you can call that, of renal disease. There's acute renal failure, there's chronic renal failure, and then there's a little bit about BPH, which is benign prostatic hypertrophy at the end of the year, and that's for male patients with an enlarged prostate. So acute kidney disease. Just by the words alone, we recognize that acute means it happened right now. It happened suddenly, it happened quickly. Chronic renal failure is somebody that develops renal disease over the course of several months, years, and there's 5 different stages of that. There are several things that can cause acute kidney injury, or AKI, that's what we call it. That you might see an abbreviation in somebody's chart that says they're in acute renal failure, ARF. It means the same exact thing as AKI. It's just how did they write the term? Just before we even start, what is something you think could cause an acute injury to our kidney? Something, medication maybe that patients can take that might cause acute injury. NSAIDs. What about cocaine? What about street drugs? Couldn't they cause an injury to our kidney? Couldn't us going into shock cause an acute injury to our kidney? That's not a chronic thing, right? That's an acute thing. That happened right now. The patient started bleeding. They went into shock. What did we say every organ in your body has to have in order to keep functioning? Blood. What's blood carrying? Oxygen. Don't we have to have oxygen to all of our tissues or they die and stop working? So that's your person that has an acute injury to their kidneys. Other things in their body might be going into shock, but your kidneys shutting down is not going to be a good thing right now. Your kidneys can't filter, they can't work. So there's different things that can cause this acute stuff to happen. It could be drugs, could be medications that we've given the patient. There are certain medications called aminoglycosides. What the heck does that even mean? It's just a category of antibiotics. They end in myosin. Remember I was talking about them? Erythromycin, streptomycin, gentamicin. They can cause kidney injury. They're nephrotoxic, meaning that they can damage the kidneys. So your patient that in the story has a renal history, let's say they're a dialysis patient, don't pick that kind of medication as an antibiotic because it's going to make their kidney function worse. You're not the one going to pick it. Obviously, you're not going to be the one ordering it, but if that's in your answer, recognize that that's a medication that causes injury to our kidneys. What else can happen to us acutely that could damage our kidneys? Infection. Hypertension is more of a chronic thing. That's chronic. What are we all doing and potentially could happen as we're driving down the road? Trauma. Any kind of trauma is going to cause acute kidney injury. What if our kidney starts bleeding because we were in a car accident? Isn't that going to be an acute injury to the kidney? The patient going into shock because they are dehydrated severely could go into acute kidney injury. So I'm just trying to help us get a picture of things that can cause an acute injury. There are things that we call pre-renal, meaning it happens before the kidneys. There are categories that are intrarenal, happen to the kidneys. And then there are categories that are post-renal, meaning there's something after the kidneys that have backed up and caused blockage to the kidney. Now, yesterday we were talking about something that would be more like a post-renal reason. What was it that you think could cause a blockage or a backup into the kidneys and create issues inside the kidneys? What's that? Purines. Stones. Yeah, stones. That's what I'm looking for. Okay, somebody has a kidney stone. Go back to the picture of, we have 2 ureters. We got a bladder. We have a urethra. There's a big stone in your left ureter. What do we say is going to happen to the drainage on that side? It's not going anywhere. It's blocked. That blocked urine backs up into the kidneys and actually, if it's large enough, can create damage to the kidneys. So that would be a post-renal issue. Benign prostatic hypertrophy. What's that mean? The patient is a male, because only male patients have prostates. Their prostate is enlarged. So now they can no longer pee because the prostate is so enlarged. The urine backs up into the kidney. the kidney goes into a failure. You see how that's more of an acute issue? The patient with chronic renal failure is the patient with hypertension and diabetes, and over the course of time, hypertension has affected their kidneys. So I just want us to recognize the differences between these two things. Acute kidney injury or acute renal failure is sudden cessation. What's that mean? Sudden stopping of kidney function that occurs because something has blocked the blood flow to the kidneys. Could be shock, could be trauma, could be NSAIDs, could be cocaine use, it could be gentamicin that the patient's taking. Something has created no blood flow to the kidney, and it happens kind of quickly, and that's what makes it acute. Chronic kidney disease is irreversible. You can't fix it. We can fix acute kidney injury. How do we fix it? Well, what's the cause? Whatever the cause is, we treat the cause. Chronic is irreversible. That's the kidney disease that happens to people when they have hypertension or diabetes, or they have long-term use of some of these medications that can damage their kidneys. Most of the time, there's something in their history that has created this irreversible disease, and it progresses through 5 different stages, and we'll talk about what those stages for. As we age, don't our kidneys not work as good anymore? So that's a risk factor right there for chronic disease. As we age, and we said our kidneys don't work, don't you think older people are higher risk for acute diseases as well? Yes, because the flow to their kidney isn't as good anymore as it once was. What happens to our nephron? Now that we know what a nephron is, it slows down working, decreases working and how much it filters. What do we say about our filtration rate? What happens as we age? Where does that go? Up or down? Down. So you'll see as there are 5 different stages of chronic disease, 1, 2, 3, 4, 5, that GFR number went from 90 to 120 to 70 to 50 to 30. People sometimes have a GFR of 10 or 15. They're a dialysis patient because the kidneys don't work anymore. So again, older adults are high risk for dehydration. They're at risk for both of these things because they're older and their kidneys don't work at all. If you've seen in some of these charts, a diagnosis that says ESRD, that means end-stage kidney disease. Kidneys aren't working. Maybe dialysis is still working for this patient. Maybe they need to be on a transplant list somewhere, but definitely it's end-stage, meaning they've reached some of the last stages of that kidney disease that's happening. So acute renal failure, when does it happen? Any condition that slows blood to your kidneys, direct damage to the kidneys, such as trauma. What if somebody gets stabbed in their back? Do crazy things happen? What if you're in a car accident and your kidney, you damage one or both of your kidneys in this car accident? Any kind of trauma like that can cause acute kidney damage and acute kidney injury. And how would we fix that? Well, we'd have to stop the bleeding. We'd have to give the patient blood products. We'd have to give them IV fluids, whatever it is to stabilize the patient. The ureters become blocked. There's that stone, or maybe there's cancer there, or maybe there's some kind of constriction there. Whatever it is that's creating that blocked ureter, things can't leave your body. It now backs up into your kidneys, and your kidneys can be affected. And that's not a chronic thing. Usually that's kind of an acute thing that happens. Something acutely has interrupted the flow to the kidneys, and again, the blood is not getting to the kidneys, and so things change. There's 4 phases, and try to remember, because this is easily confused. There's 4 phases of acute kidney injury. There's 5 phases to chronic renal failure. So just make sure you're paying attention to which one we're talking about. This is acute. Phase 1, what happened? Well, the onset of phase 1 is what happened that created this issue. So trauma, hemorrhage, taking the NSAIDs, taking the gentamicin. The onset is what happened that created this damage to the kidneys. That's phase 1. Whatever the onset is, we figure out what happened. Is this a trauma patient? Is this a patient that got dehydrated suddenly? Is this a patient that stopped drinking in the last 2 days? Is this a patient that was a trauma? Is this a patient that has been taking NSAIDs at home and all of a sudden their kidneys aren't working? So this is what happens. Onset happens, and then the initial phase of when your kidney is damaged, this is acute, you have oliguria. What's that mean? Now that we know what that word means. Look how much they put out, 100 to 400 in the first within a day, the first one in 24 hours, right? So this is what happens. Our kidney gets damaged, our kidney reacts to that and stops producing urine and tries to hold on to fluid. This is what your body does. You're not thinking about it, it happens automatically. This phase, not making urine, can last up to 1 to 3 weeks. What do you think we would be doing for that patient during that oliguric phase? I'm trying to make it as simple as possible. Do you think we would give giving them IV fluids then to try to stimulate their kidneys? Yes. Yeah. Do you think we would be giving them diuretics to try to stimulate the kidney and flush it out?
The potassium sparing one.
Yep, we got to be careful about the potassium. Yep. So look what we're doing and look what this patient looks like in that initial first couple weeks. This is right when they had damage to their kidneys, something happened, and now they have this oliguric phase. And I'm just trying to make it as simple as possible. After a couple weeks, with us giving IV fluids and diuretics and stimulating your kidneys, almost like jump starting your kidneys again, now we move into the diuretic phase. And now this can last for another 2 or 3 weeks. So now what happens when all of a sudden we recognize that the BUN's getting a little bit better, the kidneys are starting to recover, the urine output is now 3,000 or 4,000 mLs per day. Now this is when they're going to cut back on the diuretics and your kidneys are working again and doing the diuresis for you. So, and I'm trying to make it again. It can be very, very complicated, and it is most of the time. And then you have this phase, and then it goes into recovery. And it could take up to 12 months, up to a year, for somebody to recover from an acute kidney damage thing that happened to them. So all you need to recognize from this is there's 4 phases to when you acutely have an injury to your kidneys. This is not chronic disease, this is acute. There's an onset of what happened. Then there's a phase for a couple of weeks. Sometimes it's 8 days, up to 10 days, could be 15 days where the patient's not making urine. The specific gravity goes up. Why does this specific gravity go up? The urine's more concentrated. They're not making the right amount. They're not making a whole lot of it. What do you think the urine looks like in this phase? Very dark, concentrated, right? Could be that tea color that we talked about. It's not like a nice clear yellow. It's very dark. Potassium goes up a lot of times when this is happening because you're not flushing out potassium, so the potassium inside of our cells builds up. They have dysrhythmias. Look what we might give them, K-exalate. You remember us talking about that as a medication that binds with potassium and decreases the potassium. So anything in this oliguric phase, pay attention to what's happening. They're not making urine. It's concentrating, specific gravity goes up, potassium goes up. Now we know what that is, metabolic acidosis. This is a metabolic problem, right? It's not respiratory. Blood pressure goes up. So during this phase, we're going to give them diuretics, we're going to give them IV fluids, we're going to try to jumpstart their kidneys. And now they start making lots and lots of urine. You think we're going to keep on giving them diuretics at that point? No.
Isn't that they're not making fluid or they're just retaining it?
Their kidneys want to hold on to it because they say it's almost like they went into shock. They're like something got damaged. The kidneys are damaged, and they hold on to whatever they can. So they're not producing it, but what they are producing, they hold on to. Okay, to try to recover on their own, and we help them recover in that phase by giving them IV fluids. If they need blood, we give them blood. If they need diuretics, we give them that, right? Anything we can do to kind of jumpstart it. I remember taking care of patients and thinking, wait, you were giving them Lasix and making urine. Why did we stop giving them Lasix? Well, finally, after about 2 weeks, it started kicking in again. And you start noticing their urine output goes up and up. You know, and now they're putting out 4,000 to 5,000. Now we got to stop the Lasix because now what's going to happen to the potassium? It's going to go down, right? So this is more like somebody really sick with an acute kidney injury is going to be in an intensive care unit. And I feel bad for you guys because I see my son and my daughter learning this stuff at Del Tech, and they're learning it over the course of 2.5 years, and we're learning it in like 3 days. So I know it's hard, and I'm trying to make it as simple as possible. 4 phases. There's an onset of what happens. Then for a couple weeks, they become oliguric, and the kidneys aren't really producing or holding on to it. They're trying to recover from what damage happened. and now they go into a diuretic phase. We stop giving them diuretics. Look what this diuretic phase means. Recovery of the damaged nephrons. You see that there? So now our nephrons have healed themselves, basically. They're starting to work again. Our specific gravity is going to go down. It's not going to be up anymore. And the blood pressure is going to go down. You understand what's happening here? Right? There's no longer retaining all that extra fluid. They're getting rid of it now. We got to slow down our diuretics and then they recover. So this is just a quick slide to help us recognize that somebody that acutely has a kidney that's damaged, these are the 4 phases that they go through. Again, this is important. This is how do we recognize what type of damage has happened? We just talked about there's pre-renal, there's intra-renal, there's post-renal. What the heck does that even mean? Pre-renal means something happened prior to this flow getting to the kidneys that caused this acute injury to happen. So pre-renal would be there's not enough volume in my body. What can create not enough volume? Blood loss, right? Trauma. Patient being dehydrated, the patient having burns. How can burns create not enough blood volume to our kidneys? What happens to all the fluid when we get burned? It goes into our tissues. Remember, we talked about that. So because the patient is severely burned, and this is not the patient that just burnt their hand, this is the patient that had severe burns from a house fire or whatever it is. Patient with burns, all the fluid goes into their tissue. So where's it not going? It's not going to their kidneys. The patient that's dehydrated, what are they not getting? Not getting enough flow to their kidneys. The patient going into shock, what do we say our body's going to want to do? Where's it going to send the volume in our body? To our brain and our heart and our lungs. What gets left out? Our kidneys. Everybody with me? This is what your body does for shock. Automatically. Wants to save your brain and your heart and your lungs, because if they don't work, nothing else is going to work. So your kidneys kind of lose out in this shock scenario. Patient that gets septic. What happens when somebody gets septic? Where's their blood pressure go when they get septic? Down. Those are possibly going into shock. If they're septic and the blood pressure goes down, what's happening to our kidney volume? It's down too. So I'm just trying to help us think about how do I really apply this and not just memorize what's pre-renal causes and write it down, but one by one, how does this happen? So it's something that created lack of flow to the kidney. Now, intrarenal means something that damaged the kidneys themselves, like inside of the kidney. That's what intrarenal means. NSAIDs, what do you think they are? They decrease blood flow to the kidney. So which category are they going to go in? Do you think they would go in the pre-renal because they decrease blood flow? Or do they go in intrarenal where they damage the kidney themselves? Think about what they do. Look in your book.
Pre-renal, because they reduce blood flow. So
Look in your book. There's a column. Where's NSAIDs? Denise, do you have it up in your?
Yeah. That's not always
it's pre-renal.
Mhm.
and it damages the kidney from the lack of oxygen.
And decreases blood flow.
Indicating damage to the
So it is in the category of pre-renal. Here's the reason why. Cocaine and street drugs and gentamicin damage the nephrons themselves. NSAIDs decrease flow to the kidneys. So they're usually in that pre-renal kind of category because they decrease the blood flow and the oxygen that gets to the kidneys. And I had a hard time, I always thought NSAIDs, don't they damage the kidney? Is that what it says? Yeah.
I was looking over here.
Yeah. So what are things that are listed in the pre-renal categories in the book?
Kidney vascular obstruction, shock, decreased cardiac output, decreased kidney perfusion, sepsis, hypovolemia, peripheral vascular resistance, aspirin, ibuprofen, or NSAID.
Yep. So, everybody with me? This is what's in your book, and that's why I say go back and read these chapters again, because for the longest time I thought NSAIDs, well, shoot, they damage the kidneys themselves. How they damage the kidneys is decreasing the flow to the kidneys. Does that make sense? So that makes it more like of a pre-renal thing. It decreases the volume. Sepsis does that. Burns do that. Dehydration. What about somebody that had a big MI and doesn't have good cardiac output right now? Isn't that going to decrease the flow to the kidneys? So you have to kind of like think about what are things that are happening in this patient's body that are decreasing blood flow to the kidneys themselves. An intrarenal cause is something that damages the kidney directly. So there's that necrosis that we talked about. Remember yesterday we were talking about not using build up of protein. What about glomerulonephritis? What do you think that would be? That's intrarenal. That means that inside the kidney itself there's damage. Drugs do this, gentamicin. So always remember, NSAIDs and aspirin and all those things are more like they decrease the flow. That's what they do. So that's more pre-renal. What's post-renal? There it is. We talked about stones. We talked about an enlarged prostate. What about a tumor in the bladder? Couldn't that be a post-renal issue? The urine can't go through the bladder. It backs up into the kidney. Right? That's usually an acute thing. And so again, 4 phases to acute renal failure. 3 different causes, 3 different categories. And just have a general idea of pre-renal, intrarenal, post-renal, what are our causes? And here's our pre-renal causes. Shock, decreased cardiac output, the patient just had a large MI. So even though everybody's focused on their heart, what are we going to keep an eye on afterwards to tell us if the kidneys are working? Which labs? Okay, so they had an MI. We know it's a big heart attack that they had. What is the kidney doctor going to want to look at? Their BUN and creatinine. Does that make sense? Because now they don't have a lot of output from their heart. The pump's not working. They got damage. The kidneys can also now get damaged. And that's a lot of times why MI patients get sick. They die from that irregular heartbeat in the first few weeks. But then we recognize that their kidneys also got damaged by that large heart attack that they had. Okay, patient that's septic, we just talked about that. Patient with hypovolemia, that's dehydration, or they're bleeding, using aspirin because it causes decreased renal flow and liver failure. Here's your reasons why somebody has pre-renal causes for acute kidney failure. Here's your intrarenal causes: trauma, there's a clot, there's an embolism that traveled from somewhere else. What does our renal artery supply? Our kidneys, right? Arteries supply our kidneys with oxygen. Each of our kidneys has a renal artery, left and right. Contrast dye, there it is. This might be your story on NCLEX where the patient went for a CAT scan with dye, and now they came back, and the kidney is damaged, and the BUN and creatinine are up, and the patient's not making urine, right? This is your picture. What is the reason? Chemical injury and intrarenal, meaning that dye affects the kidney themselves, affects the nephron. Cocaine, alcohol can affect our nephrons and our kidneys. It not only affects our liver, but it affects our kidneys as well. And then an infection, and then that glomerulonephritis. So look how many things now we know about kidneys that we didn't know a week ago. Here's our post-renal causes. Patient has a stone, you could say renal calculi, they could have a tumor, they could have a spinal cord injury, there could be some kind of stricture under the urethra, the prostate could be enlarged. So is everybody getting the picture of what's happening, right? Something prior to the kidneys is intrarenal, some kind of damage to the kidneys themselves is pre-renal, intrarenal is damage to the kidneys, post-renal is damage afterwards. So look what happens to our BUN and creatinine. There are the numbers we're going to look at. Creatinine can go up and actually can double. So what's normal creatinine for people? 0.8 to 1.2 or whatever ATI tells us, say 1.4, I don't know what the top number for creatinine is. What's going to happen with them? Within 24 to 48 hours, you'll start seeing that number go up. And within a week, it can actually double. So somebody's creatinine could be 1, and then it could be up to 2 right away. You think, oh, that's not that much, but it is for that number because there's only a very small range for creatinine. BUN can increase to 80 to 100. What's normal BUN? 10 to 20. So see how quickly these numbers will rise when somebody has an acute kidney injury. Their kidney is damaged. It's not working. Why does the BUN go up? What's building up in their system? Urea. Why does the creatinine go up? What's building up? But what is creatinine an indication of? Muscle and protein breakdown. So we gotta go back to what we learned creatinine even means. What happens to our hemoglobin hematocrit? It goes down. Why does it go down? What's the kidney not making anymore? Erythropoietin. Right? It should all start kind of clicking here. This is what's not working, or this is why it happens. Patient goes into metabolic acidosis, and then again, the urine is going to have blood in it. The urine is going to have a lot of sediment. The urine is going to have bacteria. These are some of the labs that we would get to look at a patient that again has renal injury. Here's your key with this: the treatment for acute renal injury. Figure out what the cause is, and then treat the cause. Is it because the patient took NSAIDs? Well, then what would be your answer? Stop giving them NSAIDs, right? Doesn't that make sense? If it's because the patient's dehydrated, what would be your answer? Give them IV fluids and rehydrate them. If it's because the patient is bleeding and it's a trauma, what would be your answer? Stop the bleeding, give them blood. Everybody with me? If it's because they have a stone in their ureter, what are you going to do? Remove the stone, right? Or do that shock treatment. Look in the story for what the reason is and then treat the reason. Are we going to give them IV fluids? Yes, almost always. Because remember, that first phase is going to be they're not making urine. So we got to try to perfuse their kidneys. We're going to give them diuretics. Yes, we are. That first phase because it's going to promote kidneys to function. Remember, we got to pay attention to the potassium. It's going to go up. Be careful with how much protein you're giving them because creatinine number is a breakdown of protein. Yes, we want to give them high quality protein during that because we want them to help recover and heal from the injury. Could we possibly have to give them TPN? Why would we have to give them TPN? What is TPN used for? Total parental nutrition. What if the reason that they're going into acute kidney injury is they're dehydrated and they've been throwing up for 5 days or 7 days or 10 days, they have some kind of acute GI thing? What do we have to think about nutrition for them? Are their kidneys going to heal if they're not getting protein and things in their diet? No. So we got to think about what else could we possibly add to this patient to, again, make sure that they're getting enough in their diet for their kidneys to heal. Because the reason they're in this is there's been some kind of injury. Potassium restrictions, we pick that. Why would we pick sodium restrictions?
They're making up too much fluid.
Right, they're already holding on to that fluid. They're not putting a whole lot out. Are we going to want to give them more? We're going to give them IV fluids. That's going to perfuse their kidneys, but we certainly don't want to give them sodium because that's just going to make them retain fluid within their body and not really do much for them. So this is kind of our treatment for this patient that's in acute kidney disease, acute renal failure. Identify the cause, treat the cause. Monitor intake and output, absolutely, because their kidneys aren't working, so we're always going to want to know how much they're putting in, how much they're taking out. Look at their BUN and creatinine, look at their electrolytes. Think of the picture of this patient in your story that has acute kidney injury. What are you going to expect? BUN and creatinine to be up? Yes. Potassium to be up? Yes. And then as they recover and they're in the diuretic phase, now worry about the potassium dropping. If they're in this problem because of a nephrotoxic medication like gentamicin, what would you do? Stop the medication. Don't keep giving it because it's only going to make the kidneys worse. Monitor for heart failure. If the patient had a large MI and they're not putting enough out, what kind of meds do you think they might add to make the heart pump stronger? Go back to our categories of heart meds. What are our categories of heart meds that help our heart pump more effectively?
Beta blockers.
Say it. Beta blockers. Yep.
Synchronous.
LOL. Take that. Why? Because we're going to help the heart pump stronger and more efficiently, right? Because the heart pumps stronger, isn't that going to help our kidneys? Right? So you have to kind of all put it all together now. And like, why are we doing the things that we're doing? If it's an infection, like glomerulonephritis, wouldn't we pick to give them antibiotics to treat that? Because it's an intrarenal cause of the problem. So again, this is just helping us think, whatever the reason is, figure out what it is, and then treat the cause, and think about select all the 5 things that you would be doing for this patient. Okay, next category is chronic renal disease, and I'm going to get through all of it, I promise. Okay, so everybody okay with what acute kidney injury is? We learned that in like 7 slides. We could stand here all day long and talk about that. All we need to recognize is that there's 2 different types of kidney disease, acute and chronic. Acute has 3 different causes, right? Intrarenal, prerenal, postrenal. Acute has 4 phases. What are the phases? And just recognize what's happening in those phases and how to be treated, okay? Simple as I can make it. There is, whatever chapter it is that you're looking at there in your book, talks about acute kidney injury and what that even means and what do we expect and what kind of labs will we get. Most of the people that we're going to see, unless you work in an ICU or a trauma unit or whatever, is going to be chronic renal failure. What the heck does that mean? That means it's lasted a long time. And over time, the kidneys have gotten worse and worse and worse. Can we reverse this? No, we can't reverse it. All we can do is try to keep it from getting any worse for the patient. We can't change it, and that's why we call hypertension the silent killer. Hypertension is the leading cause of kidney disease. People, again, don't recognize hypertension until they have a lot of symptoms. And then they start trying to take meds, but by the time that they do, some of the damage has already happened. So there's 5 stages of kidney disease, chronic kidney disease. Lots and lots of risk factors. What do you think some of our risk factors could be for somebody to develop chronic renal failure? Hypertension's the first one. What else? Diabetes. Why diabetes? What do I keep saying about the sugar, right? The sugar in the blood's not flowing as easily. Because the blood's not flowing as easily, it's more concentrated, it's thicker. What do you think's happening to the flow to our kidneys? It's only going to be a little slower, right? So over time, you can see how this can create issues for chronic renal failure. What about age? Wouldn't that be a risk factor? Yes. The older we get, what do we say? The less nephrons work, right? That happens. African American in this category of more likely to have renal disease because they're more likely to have hypertension, right? That's just one of the risk factors. So again, whatever the patient is, what if IV drug use over the course of years and years and years put us at risk for this? Yes, it can damage our kidneys acutely, but couldn't it make chronic disease as well? Can somebody have an acute kidney injury and be in chronic renal failure? Yes. It could be a dialysis patient that now is a trauma patient. Now we got 2 things happening to their kidneys, right? So you can have both things at the same time. If somebody has a diagnosis on the chart that says ESKD or ESRD, it's end-stage renal disease, and most of the time they've either been on dialysis, or maybe they're going to get a transplant, or maybe we're not going to fix their kidneys, and they might be a hospice patient. Right? It just depends on what's happening and what stage of life that patient is. It's very common. Again, don't worry about these numbers, but a lot of people have it. Usually not a lot of symptoms until later stages. Here's our typical top risk factors: diabetes, hypertension, being over age 70. Kidney function decreases 1% per year after 50. That's kind of the general number. So I'm 53. What does that mean? By 3 years ago, right? Every year, about 1% of my kidneys. I mean, what does that tell me? I should control my hypertension, right? I should take meds. I should watch my diet. I should try to eat better. I should keep my kidneys perfused the best that I can. Because the older they get, the more likely that this can possibly develop. And again, if you have this, what you're trying to do is eliminate getting any worse, eliminate the causes. Take your blood pressure meds, monitor what your diet looks like, make sure your kidneys are perfused, drink enough fluid every day to keep your kidneys perfused, whatever it is you can do to try to slow things down. Here's our risk factors again, we just talked about it. Anything in here could potentially cause this chronic disease to happen. Progressively worsens. Here's some of the signs and symptoms that people with chronic kidney disease have. And again, you're going to be taking care of a lot of people that have hypertension, have diabetes, and then end up with kidney problems. A lot of patients have these issues. So progressively it worsens. We can't change it, but we can try to stop it from worsening. Neurologically, what does your renal patient look like? They're tired. We said this already. They're anemic. They have dizziness, they feel weak, they might have tremors, they could have seizures, they could go into a coma. What do you think is building up in their body and in their system? What if it's a liver issue? Ammonia level could be getting high. Their potassium level could be high. What else could potentially end up being high? BUN, creatinine, all this whole picture of the patient is on this PowerPoint right here. This is what your renal patient typically looks like. They usually have fluid overload. We already talked about that. It's not fluid deficit. They have too much fluid because their kidneys aren't working and aren't helping us get rid of fluid. That's why we go to dialysis to begin with, to help pull off that extra fluid. They have JVD. What the heck is that? Jugular venous distension. You know what that is now. They have peripheral edema. Where's their blood pressure going to be? It's going to be higher because of the fluid they're holding on to, right? Everybody with me? We've already talked about this. They come back from dialysis. Now what? We're going to expect it to be lower because we just did everything that your kidneys haven't done in the last 2 days. We did it for you. They have dysrhythmias. What's uremic halitosis? What's halitosis mean? Bad breath. That's a word for bad breath. Why don't they say bad breath? I don't know, but they call it halitosis. So these kidney patients have pruritus, that's itching. Halitosis is bad breath. They yawn a lot. Why? They have a lot of increased intracranial pressure, less oxygen traveling around. Yawning frequently is a sign of increased pressure in your brain. So these patients have that bad breath, they feel tired, they're weak, they have fluid in their lungs, they have peripheral edema. This is your renal patient. This is what they look like. And a lot of times we start noticing little things, and then over the course of time, as the disease progresses, they get worse and worse and worse. So your end-stage renal patient, most of the time, has this full of fluid, swollen, feet are swollen, they have trouble breathing, they want to sit up because they can't breathe, they need oxygen, they have that yawning that happens a lot. Again, they start throwing up. I mean, these are all the things that happen with that end-stage renal patient. So not every one of the patients are going to have every one of these symptoms, and these are things that you would notice for patients that have renal disease, and this is chronic renal disease. They feel weak, they're dizzy. Why do you think they have bruising and petechiae? Why do you think they have that? Aren't they anemic? Aren't they not making enough hemoglobin? They're not carrying around oxygen. Many times, hand in hand, problems with the kidneys affect our liver. What does our liver do? Our liver produces all of our clotting stuff, right? So you got the picture of this patient that is a renal patient. Many times they're bruised on their arms and their legs. They have this little petechiae. They're nauseous. They have this, what we call uremic frost. Is that on here? Yep, there it is. Crystals on their skin. I think there's a picture. It's hard to see that this person has uremic frost. You see that like white powdery kind of stuff on their skin? It's itchy, it's flaky. You ever taken care of a renal patient, you know what I'm talking about. Their skin's dry, they're always tired, they feel weak, they sometimes feel nauseous. This is from the urea that's building up in their body. The kidneys aren't getting rid of it, and it creates what we call uremic frost. Has anybody seen that come up like in questions or anything? So that's their skin. What would we do for that patient that has pruritus and that uremic frost? Wouldn't we put lotions and bath oil and things like that, right? Wasn't there a question about cutting their fingernails shorter? Yeah, do that. Do that so they don't itch and scratch. Tell them to wear long sleeves. Because what happens when you have poison ivy, right, or something that makes you itch and you see it, doesn't it make you want to like scratch it? So cover, they a lot of times they'll tell renal patients wear long sleeves so they don't start itching. I've had renal patients that literally have itched themselves and they're bleeding because it itches so bad. What can we give them for itching? It starts with a D. It's an anticholinergic. The other name is Benadryl. Diphenhydramine, right? There it is. That is used for itching. Pick that. You can give them that for itching. So this is what your renal patient looks like. This whole slide here. Bad breath, weak, bruising, thin, fragile bones. Why? What are they not making? Calcitrol, right? So they don't make vitamin D. They don't make enough calcium calcium, right? Everybody got the picture of what our kidneys do, and this is what your patient looks like. So think about their bones, think about them being tired, think about them being weak,
So that's from the
monitor their blood pressure. What's that?
From the PPI drugs, like osteoporosis, stuff like
Well, not even from PPI drugs,
that.
just because their kidneys don't make erythropoietin, calcitonin, and renin anymore. Remember, that's the three things our kidneys make. PPI drugs create weak bones just because that's the side effect of those. So PPI is used for GERD, right? Not for these patients, unless they have GERD too. I mean, but again, this happens because our body and our kidneys aren't working like they normally do. So look at this picture. Remember, these are going to be the symptoms that you would expect this renal patient to have. And there's that uremic cross picture. And here's some of our symptoms. Again, you might not have it until later stages. They usually get nocturia. They tend to, their body wants to pee more at nighttime. They get short of breath because they have all this extra fluid. They get swollen feet or ankles. They get dry, itchy skin. Remember, that's called uremia. Difficulty concentrating. It's irreversible. It's long-term. We monitor it. About what stage of this? There's 5 different stages. About what stage do you think we're going to start thinking about dialysis for this patient? 4, 3. 3, why? Well, why can we not wait till 4 or 5? What do we have to maybe implant into them to try to get it ready for dialysis? Our fistula, remember? So it takes 2 months, 4 months. We don't want to wait till you get all the way to stage 5 and say, okay, how are we going to give you dialysis? And that sometimes does happen. But this person with chronic disease is actually followed by their doctor pretty closely, followed by a nephrologist. Okay, what's your filtration rate now? How are we going to get that? They get stuff, they get blood, and we monitor what stage of kidney disease are you in, and we start thinking, okay, when you're starting to hit stage 3, we better figure out how are we going to do dialysis on you, because you're going to be needing dialysis probably within the next few months, right? So we just start planning ahead of time. So here, let's go to where our stages are. Here it is. Stage 1, minimal kidney damage. Your GFR is right around 90. Remember, what's your normal filtration rate? 90 to 120. What is that number even mean? It just means how effectively is the glomeruli in your kidney working. Look at what happens in stage 2. Now we're somewhere between 60 to 90. Now we're down to 30 to 60. Now we're down to 15 to 30. Stage 5, we're less than 15. About here, stage 3 is when we got to start thinking, okay, this is progressing. What kind of access are you going to have if you're going to need dialysis? Are we going to consider peritoneal, or are we going to consider hemodialysis? These are the conversations that would be happening with the patients and their doctors. End-stage kidney disease is this when 90% of the kidneys or nephrons aren't working. Dialysis can maintain life, but neither is a cure. It doesn't make it go away. It just now replaces the kidneys that are no longer working. So this is another chart that basically just kind of talks about 1, 2, 3, 4, 5. What happens in each of these phases? What would be some of our guidelines if we were notice that our GFR is starting to go down and our BUN and creatinine are just starting to go up a little bit, and the patient has high blood pressure? There you are in stage 1. So what are you going to tell your patient to do in stage 1? Monitor their diabetes, monitor their blood sugar, take your blood pressure medications, frequent monitoring your blood pressure, right? This makes sense. Things that you can do right now so you don't progress down this chain of chronic disease. And again, we're thinking about dialysis about stage 3. How are we going to get this patient? So what are we doing? In stage 1 and 2, not so bad, just lifestyle stuff, take your blood pressure medications. Key is we're trying to stop the progression, maintain your blood sugar. What about smoking? What is that going to do? Vasoconstriction. What does that do to our blood flow to our kidneys? What was it? What do we tell them to stop smoking? Right? What do we tell them? Exercise. What does exercise do for our body? It increases the flow that we get to all of our organs and our brain. There's lots and lots of good benefits from exercising. And we all say, oh, if only I had the time to exercise. None of us have time right now, right? Maybe when spring comes, we all start walking around the parking lot at lunch, right? Something, because it really does, it does help. It helps our lymph system, it helps our heart, it helps our kidneys get more perfusion, it helps our lungs. So what do we tell this person to exercise? Yes, even if it's just 30 minutes, 3 times a week. That's gonna help increase the flow to your kidneys. What about their diet? We want it to be lower in sodium and potassium because we don't want your kidneys to have to work harder. So this is what we're telling them in stage 1 and 2. Now, again, lifestyle changes. That's all. They take your medications, monitor your cholesterol, no smoking, don't take NSAIDs, right? Monitor things that can make this get a little bit worse. And now we're in stage 2. And now I might add an ACE inhibitor to directly affect the kidneys and lower the blood pressure. Again, all the same stuff is happening. Healthy lifestyle changes, monitoring your blood pressure, monitoring your blood sugar. It didn't change, it doesn't go away, but now we've added more medication. And then stage 3 is when we start talking about, like I said, what kind of fistula are we going to put in? Maybe that's what we need to do right now because we need it to mature and be ready to go when we do the dialysis. Every patient doesn't have the same signs and symptoms, so it's only based off of the numbers can we tell what stage you're in. Now we're just managing it in stage 4, and then stage 5 is end stage. So again, just go through the chart here, just recognize there's 5 different stages, and based off of those stages, what are we going to do for this patient? What else? Phosphorus. What do we say about kidney people and phosphorus in their diet? Do we want them to have phosphorus, or what happens? Lower phosphorus in their diet? Here's your foods that contain phosphorus. Oh my gosh, more nutrition. How are we going to remember, right? What has what in it? There's some of the things that we tell them not to eat because they develop high phosphorus because their kidneys don't work anymore. There's a medication, that we talk about this called Foslo, that we give kidney patients every time they eat a meal. Just like we give pancreatic patients enzymes, we give these patients Foslo. Well, how do you give it? You give it with every single meal. Why? Because if they're eating things that have phosphorus in it, what do you think the Foslo does? Decrease. Binds with the phosphorus in the food and helps decrease how much your body absorbs. So you'll be giving kidney patients something called Foslo. What's the key to that? Give it every time they eat, because you don't want their phosphorus level to build up in their body. So here's some things that have high phosphorus in it. Here's some signs and symptoms that we talked about. And again, uremia is increased BUN and increased urea in our body. There's some GI symptoms, some skin symptoms we talked about. Monitor their platelets, monitor their bleeding tendencies. They're in metabolic acidosis. They're anemic because they don't have erythropoietin. Again, just trying to see. Look at the numbers here for renal failure. This is sometimes comes up in NCLEX questions. Have you had anything that says like their creatinine is now 1.8? What would you categorize this as? It's mild renal insufficiency or mild renal failure. Look at normal numbers, 0.6 to 1.2 or 0. What is that? Is that our ATI number for creatinine? 0.8 to 1.1. Is that right? Yeah. 1.4 or 1.1? 1.1, I think. Okay, so look what happens. Again, don't get all mixed up in, oh my gosh, which stage are they in? But look at their creatinine when they're in renal failure. It's greater than 8. Look at their BUN. It's going to be 30, 40, 50, whatever it is. We know what normal BUN is. So look at this patient that's an end-stage renal disease. You see how high their creatinine is? Don't get yourself like, how am I going to ever remember every single number? Don't get caught up in these numbers. Just recognize what normal creatinine is. If it's a little bit higher, we're going to say they're in mild renal insufficiency. If it's 8 or 10, what do we think they're in? End-stage renal disease. Does that make sense? It's really, really high. It's not just a little bit high. So again, I don't want us to memorize a whole bunch of numbers and then the numbers look a little different on NCLEX than what we're used to. So let me go back to one more slide right here. What are we going to do for these people if we're taking care of them? Here's some labs that we will be getting. UN, creatinine, electrolytes, right? What do we expect? Protein might be in their urine. Why? Because their kidneys aren't working right. The protein's going to build up and get in their urine, and we're going to see it. Here's the medication to decrease potassium. Look, right, put a little star next to this, because if your story on NCLEX says the patient has a potassium of 5.8, what do we think about that? Too high. Don't we have to get that down right now? What's going to happen to their heart if they have a high potassium? It's going to slow down. Most patients with a high potassium will have a lower heart rate because it slows them down. Can they still have irregular heartbeats with a high potassium? Yes, they can. What's the most likely thing with potassium that causes irregular heartbeats? Low potassium. So this patient, as a renal patient, we worry about a high potassium because their kidneys aren't working. So here's a med called sodium polystyrene. How are you going to remember that? It's going to have two words. K-exolate is the name that is the generic name that we talk about every day. But sodium polystyrene, what does it do? The patient drinks it. It's a thick, brown, yucky, sugary, kind of tasting liquid. And I've given it to patients and they're like, how am I going to drink that? It looks nasty. Have you ever seen it?
Yeah.
It looks yucky. Can we give it other ways? You can give K-exolate as an enema. If the patient had an NG tube in and they couldn't tolerate taking it, or had a tube in that was going to suck it right back out anyway. So K-exolate can be given usually by mouth. If the patient can't take it by mouth, you can give a K-exolate enema. And how the heck do I do that? You put like 60 mLs of that brown liquid in an enema tube or bag and put it into their rectum. And they absorb it that way. Over the course of once, yeah. You hook the enema bag up to them, they lay on their left side, and you infuse the K-exolate right through the enema. And the patient absorbs, just like if they were getting a suppository or whatever, or an enema to help them go to the bathroom. What do you think they're going to do after they get that K-exolate? They're going to poop. And then the potassium, it binds with the potassium in their system. How it works, I don't know the mechanism behind it. So K-exolate can be taken by mouth, it can be given as an enema. The name for it is sodium polystyrene. What's that for? A high potassium, not low, but high. Life-threatening high potassium. Again, what are we going to do? Restrict their sodium. We're all good with that. We know why, because sodium retains water. We might give them erythropoietin. Remember I talked about how we give that epogen with dialysis? What does that do? It helps stimulate this to be produced, stimulates red blood cell production. We might give them iron. Why? Because they're anemic. Many times that iron is extra support to help make red blood cells. So these are some of the meds that are listed here for the patient that has chronic kidney disease. Lasix, why? Lasix is a diuretic. It's going to help stimulate their kidneys and help keep perfusion to their kidneys. So, and last slide, here's our care. This is an important slide. This is you, you're the nurse, you're taking care of this patient. Whatever slide number this is, put a little star next to it because this is going to be some of the stuff that's on your test. What am I doing for this patient that's in chronic renal failure? It doesn't matter what stage you're in. What am I doing? I'm going to monitor it and take an output, right? Makes sense. I'm going to monitor the vital signs. Remember, I'm going to get their weight every day because they're in renal failure. And what do I want to know? Every time they gain a kilogram is equal to a liter of fluid more in their body. So pick that. Every day, weigh this patient. 1 liter equals 1 kilogram. Keep telling yourself that in your head. 1 liter equals 1 kilogram or 2.2 pounds. So if I'm weighing this patient every day and they were 50 kilograms and now they're 52 kilograms, what does that mean? They've now retained 2 more kilograms, 2 more liters of fluid. That's a lot. That's like taking a 2-liter bottle of soda that's now circulating in your body. And so that's why we weigh them every single day. Check and monitor the vascular study. What's that mean? Where's their AD rate? This is what you're going to be doing for this patient. Control their protein. What they're taking in, control how much of it is. We want them to have some, but not overdo the protein intake. Again, restrict the sodium in their diet, restrict the phosphorus. Restrict the potassium. What kind of diet are we gonna give these people? High carbs, why?
Energy.
They need energy. High carbs, moderate fat. Okay, here's her skin. Remember, the skin's dry, it breaks down easy, so skin care is important. Balance activity and rest, promote skin care, monitor the lungs. All of these things are what you're going to be doing with the patient that has chronic renal disease. Now look at the last thing on there. Calcium carbonate, that's that Oslo. That's the name that you're going to see. What does it do? It binds the phosphates in foods. Give that to the patient with their meals. And the purpose of this is to bind with the phosphorus. So this is not the patient, and again, remember, in Utopia, you have one patient. You don't have 24 people you're giving meds for, right? When are you going to pick to give this? When they eat. Don't tell yourself, okay, it's okay to give it 2 hours later. It won't do anything 2 hours later. Everybody understand what I mean? So pick it, give it when they eat. You only have one patient, you have enough time. Now, in real life, will you always get in there before the breakfast tray comes? Not always. So you just have to think, I want to give this with the meal, because it's going to bind with whatever they're trying to absorb in their stomach and not increase their phosphorus too much.
Don't tell them the same thing.
Tums or calcium, they could be the same thing. Yep. Again, chronic kidney disease, this is just, kind of our maintenance for them, frequent rest periods we talked about. So understand what a renal diet means, okay? Because you're going to get questions about what is a renal diet consist of. Low potassium, high carbs, lower protein, okay? Calcium carbonate, there it is, binds the phosphorus, take it with meals. Low sodium diet, low potassium diet, monitor their blood pressure, monitor their electrolytes. Remember, don't give them antacids that contain magnesium, right? Don't pick that, because they can't get rid of the magnesium, they can't get rid of the phosphorus. Don't give them NSAIDs. This is your care for the kidney patient and different meds that they can and can't take. And then start by the filtration rate and talk about the different stages. Are everybody okay with chronic kidney disease? BPH we'll talk about Monday and go back over some renal stuff on Monday. This is too much to be thrown into today. That's all the next slide. Okay, so yeah, that's long. Okay, everybody at home, good?